Hello everyone and welcome back. This video is childhood rash infections. So let's see what's in store for this video. Now in this video we're going to go over chickenpox, rubella, measles, the Roseola Infantum and the Erythema Infectiosum, and finally we'll finish with Scarlet Fever. So I hope you're getting comfortable and let's get started. Okay, so how to basically approach, and this is what we go through all the time, is how to approach the RAS questions on the USMLE. Well, first of all, we have to see the associated symptoms, and then the rash features, so the time frame, and the specific features if we can manage to spot them, clinical associations and the complications of them, and of course the treatment or the vaccines, and finally household recommendations. So let's start with chickenpox. Now primarily the infection is of the varicella zoster virus, the VZV, and most frequently during childhood. The transmission is a respiratory droplets and they are highly infectious. There is a direct contact with vesical fluid. Now, vertical transplacental transmission can occur, so they are part of the torch infections. And remember, of course, direct contact when they don't do it a lot, and of course, but many times when a child was ill with chickenpox, the mothers would send their children as well to get immunized, so they would get also the chickenpox as well. And notice as if that child hasn't had one. So in other words, just when thinking of that, you remember that it's also direct contact. Okay, so now the condition is contagious for 24 hours before the rash starts and stays contagious until the lesion begins to crust. So as long as you have those vesicles, fluid vesicles there, even when they erupt, but once they become their crust, that's when it is already not contagious. Now it has a prodrome phase, a mild fever, and of course the usual atypical, the usual non-specific symptoms: myalgia, appetite loss, and malaise. So rash, if we're looking here at the picture, kind of get that image in your brain. Will help you. Once you have the image strongly burnt in that memory, it'll help you to answer the questions correctly. So the rash appears 24 hours after the onset of the symptoms. These are small red papules, and they have this teardrop vesicle filled with a clear fluid on an erythematose base. Now this fluid later on becomes opaque, and the vesicle ulcerates and crust is formed. It has itchy, so itchy rash begins all over the body and can involve also the mucous membranes. Now consider, of course, that the non-contagious stage is only once crust appears. Lesions in different stages of healing can be seen simultaneously: papules, part vesicles, and part crust papules as well. Now the diagnosis of chickenpox is primarily clinically based: symptoms, history, and presentation. If complicated disease, then a Zank smear, which is done best initially, or a viral culture or blood, or vesicular fluid is more accurate. So again, the Zank smear is the initial test, and the vesicular fluid is the more accurate. The treatment, of course, is observation and reassurance and systematic treatment. So we treated the patient symptomatically. It's self-resolving in healthy children. Chickenpox occurs only once as a lifeline immunity persists. The primary infection is in healthy adults results in a more severe course. So in adults we would give a pyrocyclovir. The VZV, varicella zoster virus vaccine, is a live attenuated, given at 2 doses at 12 to 50 months and at 4 to 6 years of age. Now contraindication for of course the immunocompromised and pregnant patients. So if a non-immunized pregnant woman acquires primary varicella infection, IgG will not be present and the infant is unprotected. IgM cannot cross the placental barrier. Red cells immunoglobulin VZIG abbreviation is indicated ASAP in this patient. Now, post-exposure management to chickenpox. After household contacts of the unvaccinated and the non-immunized individuals, we should administer a varicella vaccine. After sick contact in immunocompromised patients, the VZ immunoglobulins and IV acyclovir should be given, and the VZ immunoglobulins should also be given to neonates born to infected mothers. Okay, shingles. This is the second part of the same virus, aka herpes zoster, painful manifestation of the varicella zoster infection seen primarily in adults over the age of 50. Now, the vesicular rash is one or two adjacent dermatomes. As you can see, here's a lovely dermatome marked in this picture. Results from the reactivation of a latent, this is a latent VZ virus within the dorsal root ganglion from a previously infection or from a reinfection of adults. Now, the treatment is acyclovir, and this decreases the incidence of post-herpetic neuralgia. The preventable shingles is preventable taking zoster vaccine, which is a higher dose version, and is indicated to all patients above the age of 60. Reye's syndrome. Now, this is an acute fatty degeneration of the liver and the hepatoencephalopathy. Children who receive aspirin for a viral illness, for example, influenza A or B or varicella zoster virus. Now, there are a number of stages in Reye's syndrome. Stage 1, patient will feel lethargic, sleepy, and vomiting. Labs will indicate liver dysfunction testing. Stage 2, there's a deeper lethargy, patient's confused, delirious, agitated, and start to hyperventilate. Stage 3 would be the obtumed, and seizures may start to appear. In stage 4, seizures are accompanied by a deeper coma, and in stage 5, the comatose patient, the areflexia, and respiratory arrest. Now, the labs is going to show an increase of ALT and AST and increase in prothrombin time, and of course ammonia. Now, the head CT will show diffuse cerebral edema. Aspirin is avoided in children. Acetaminophen or ibuprofen are recommended, except of course in children with a Kawasaki disease. Rubella. So, rubella is also known as the German measles, and childhood infections caused by measles virus. The disease is mostly seen in areas where low vaccination rates of the MMR vaccine. The transmission is respiratory droplets, vertical transplacental transmission, and the rash typically begins as a macular papilla on the face or post-auricular. Now, within 24 hours, it spreads downwards to the rest of the body, developing a generalized rash. Its non-specific symptoms are fever, malaise, headache, aphalalgia, sore throat, and conjunctivitis. There's also a cervical post-auricular lymphadenopathy. The Folchheimer sign are the small red petechia of the soft palate or the uvula. So remember, in rubella, there is a palatal petechia, not ulcerations, but petechia on the palate. Now, in treatment for rubella is mostly observation and reassurance, and of course, symptomatic treatment. This is self-resolving in healthy children. The diagnosis is by the detection of the rubella-specific IgM antibodies. Virus indication using reserve transcriptase polymerase chain reaction. The MMR, the mumps, measles, and rubella. This is a live attenuated vaccine given to children in 2 doses Unless, of course, MMR contraindications. Remember, one would be immunocompromised patients, and two would be pregnancy. So primary infection during pregnancy may result in a transplacental transmission and congenital rubella syndrome. Remember, that would be cataract, cardiac malformations, pathoductus arteriosus, also associated with rubella, and sensorineural hearing loss. If a woman receives MMR vaccine, instruct to avoid pregnancy for at least 28 days. Now, with the sensorineural hearing loss, there's been a few times where they love asking, they give you a list, and they very crudely put in conductive hearing loss when they actually rubella. And so make sure you remember it's a sensorineural hearing loss, and that you pay attention to the answers, that you don't just whiz through and say, oh, hearing loss, and you'll lose that mark. That would be a shame. Okay, measles. Now, the childhood infection could be by measles virus. Transmission would be respiratory droplets, are highly infectious, and of course, through direct contact. The disease is mostly seen in developing countries and areas with low vaccination rates. Incidence declines significantly by the MMR vaccine. Now, the presentation, of course, there will be a prodromal stage and the 4 C's seen early in the course before the rash. So there'll be a cough, a corrosive or retinitis, conjunctivitis, and a Koplik spots. Now, there's a low-grade fever, also classic during the prodrome, and then a generalized lymphadenopathy may also develop. The Koplik spot, part of the 4 C's, is white-gray spots with surrounding erythema on the buccal mucosa and resolves before the appearance of the rash. So we can see the rash itself of the measles, and this is the prodrome is following by high fever and rash. The erythematous maculopapular rash that starts on the face and spreads to the extremities and trunk. Now, the diagnosis is primarily clinically based on the symptoms, history, and the presentation. If serology is done, detection of measles-specific IgM antibodies. Measles viruses can be identified using reverse transcriptase polymerase chain reaction, RT-PCR. Now, the treatment, again, is observation, reassurance, and symptomatic treatment. Self-resolving healthy children. The prognosis is good in uncomplicated cases. Newborns and immunocompromised are more likely to suffer from complications. Vitamin A is often administered if younger than 2 years of age. Preventable with active immunization with MMR vaccine. Again, this is the measles, mumps, and rubella. The disease is highly infectious disease. Complications would be otitis media, pneumonia, subacute sclerosing panencephalitis, fatal progressive neurodegenerative disease which occurs years after the infection. Erythema Infectiosum. This is known as the 5th disease, or the slapped cheek disease, caused by the parvovirus B19 infection. Now, the transmission is a respiratory droplets. The presentation, most often seen in children 4 to 10 years old. The first is a non-specific symptoms, low-grade fever, chorea, headache, and nausea, followed by erythema of the cheeks, and that's why they get the name, the slapped cheek appearance, and the induration erythema surrounding bipolar. Now, this is followed by a maculopapular rash with lace-like pattern on the limbs and trunk. The rash is worsened by hot showers, sun exposure, and fever. Other possible presentations of the parvovirus B19 infection in adults, this is associated with arthralgia and myalgia. There's a transient aplastic crisis that can occur, and the infection and destruction of erythroid progenitor cells within the bone marrow, seen in patients with sickle cell, iron deficient anemia, and hereditary spherocytosis. Multiple blood transfusions may be required, and most patients make a full recovery within 2 weeks. Hydrocephalus is a vertically transmission in the uterine infection, which may result in severe anemia and congestive heart failure. Now, the diagnosis for Erythema Infectiosum is the classic rash. It's present and clinical diagnosis can be made without labs. The Erythema Infectiosum should be confirmed by serology and B19 specific antibody testing, presence of an IgM antibodies, or by a seroconversion of IgG antibodies. The viral DNA by PCR is vital for the diagnosis of a parvovirus B19 infection in patients presenting with transient aplastic crisis. The treatment is observation, reassurance, symptomatic treatment, self-resolving in healthy children. In patients, of course, with arthralgia, we'll give acetaminophen, and if there is a case of a plastic crisis develops, then we would administer blood transfusions. Roseola Infantum, also known as the AK6 disease, is caused by a human herpes virus 6, the HHV6 infection, and is less commonly due to the HAV7. Now, the transmission is unknown and usually acquired from an asymptomatic adult carrier. The virus infects and replicates in mononuclear cells. The presentation most often seen in infants between 6 to 8 months, characterized by an abrupt onset with high fever lasting several days. As the fever begins to subside, rose-colored, diffuse maculopapular rash, hence the name Rosella, throughout the body, which lasts about 24 hours. High fevers may induce convulsions due to the febrile seizures. Now, the diagnosis is primarily clinically based, and PCR or viral culture confirmation is required. Treatment, observation, reassurance, symptomatic treatment, self-resolving in healthy children. High fever is treated with acetaminophen. Scarlet fever. Now, childhood infections caused by Streptococcus pyogenes, this is a group A streptococci, and consists of pharyngitis and diffuse erythematous rash. Bacterial production of an exotoxin A. The presentation, most often in children between 4 to 15 years of age, with fever, sore throat, and odynophagia, so painful swallowing. It is they are also followed with non-specific symptoms like malaise, headache, chills, myalgia. Presentation usually shows a white-coated tongue, hence the name the strawberry tongue, and an exudative pharyngitis or a tonsillopharyngitis, so enlarged, reddened tonsils with yellow or white exudates. Also be found in scarlet fever would be a cervical lymphadenopathy. Now, the rash appears 1 to 2 days after the onset of the symptoms. Diffuse erythematous papular eruptions, small red bumps, often described as a sandpaper-like texture. Begins on the neck and the groin and then spreads to the rest of the body. Blanching when applying pressure. The rash also is followed by a desquamation over the trunk and the extremities. The rash typically lasts for 5 to 6 days, but desquamation may last for weeks. Now, the diagnosis is primarily clinically based on the symptoms, history, and presentation. Confirmed with rapid streptococcal antigen detection test, aka rapid strep test. If it is negative, a throat swab and culture is most accurate. Now, other suggested tests would be a leukocytosis, high anti-streptolysin, O titer, ESR, and CRP. Treatment is similar management as in the streptococcal pharyngitis. Now, antibiotic decreases the length of illness and prevent complications with the rheumatic fever. For all patients, PO, Pyros, penicillin V, or Pyros amoxicillin is given. If there is a penicillin allergy, so the first generation cephalosporin or macrolides like clindamycin should be administered. Tonsillectomy should not be routinely done in children, and patients are considered non-contagious 24 hours after the initiation of antibiotics. Now, the complications of scarlet fever, remember acute rheumatic fever, This is an acute immune-mediated multi-system inflammatory disease, occurs 2 to 4 weeks following an episode of a group A streptococci pharyngitis. Rheumatic heart disease, acquired heart disease in childhood and adolescence, and with repetitive episodes of rheumatic fever, results in a valvular damage of the heart. Now, finally, the post-streptococcal glomerulonephritis, 1 to 2 weeks after group A streptococci pharyngitis or episodes of impetigo, unlike rheumatic fever. In many cases, when they'll ask these questions, they'll say 2 weeks ago he had a cold, or 2 weeks ago he felt ill and had a flu-like symptoms, and that's what they usually ask. And then they'll say there's a problem with the heart, or they'll describe a glomerulonephritis and so forth. So they always tell that he had a 2 weeks ago we had some kind of felt was ill, and then this happened, and that is basically the complications of a scarlet fever in many of the cases. Alright guys, favorite part of our video, question number 1. So here we go. A 2-year-old boy is brought to the pediatrician by his mother, complaining of a red rash on the child's face and body. According to the mother, the rash first appeared on the boy's face and then spread downward. Some days before the rash appeared, the boy was coughing, had red eyes and slight fever. The mother also noticed whitish spots inside the mouth, which felt like grains of sand. The boy visits the local kindergarten and has no sick contacts at home. When asked regarding the vaccination records, the mother declared, "We don't believe in vaccinations, and my children haven't received any vaccinations due to religious reasons. Which of the following is the most likely responsible for this patient's presentation?" Now, obviously, it's not going to be chicken pox, because we would want to see also, it would start from the head downwards, and we would also want to see some kind of mention of vesicles, so we can exclude C. Both measles and rubella start from the head. Human herpes virus usually starts from the groin, so the most cases would be the measles and the rubella. And the measles and the rubella are also part of the MMR vaccination. So we can exclude cDNA and we're left with A and B. Now, how can we differentiate between the measles and the rubella? And that will be the so-called whitish spots in the mouth, which felt like grains of sand, and that is the beginning of the onset, one of the so-called the Copics, so the 4 C's, seen in measles virus. So A is the right answer. Okay, question 2A. A 4-year-old girl is brought to the pediatrician with a rash. Yesterday she had a fever of 38.8 and was complaining of a headache and body ache. And this morning it appeared all over her body. According to the mother, many children were recently sick at this girl's daycare. When I came, so this is highly contagious. When I came to take her the other day, it looked like an hospital. Vital signs is obviously temperature high, 38.6, heart rate 90, blood pressure 130/79, and respiratory rate 22. And oxygen 98%, room air. The rash is distributed diffusely over her body, but most prominent on the upper chest. On exam, vesicles on an erythematosed base. Other lesions, including papules, crust papules, and hypopigmented lesions, which means they're see-through fluid, are also seen. Which of the following is the most appropriate next step in management? So, obviously, she has varicella zoster. This is, of course, the varicella part, the chicken pox, highly contagious, especially in the first days. The patient itself has already some crust, which means that it's out probably of that contagious time. Now, what is the best next step in management? Observation is a healthy girl. This is an observation, reassurance, and, if needed, symptomatic treatment. So that is the right answer. Now let's just quickly go over the answers that were given that were wrong. But again, When we administer a varicella vaccine, this is for household contacts in the non-immunized healthy adults. Pyrocyclovir is primarily for healthy adults. IV would be for immunocompromised patients, and this we will also give immunoglobulins. Now, administer immunoglobulins to non-immunized pregnant women acquiring primarily varicella infections, and to the neonates born from the infected mother. That's when we give the zoster immunoglobulin. So again, in this case, the girl, observation and reassurance. Okay, 2B. After discussing the mother diagnosis with the diagnosis and management of chickenpox, she is very concerned about the grandfather who lives with them in the same house. The girl's grandfather is 75 years old and end-stage renal disease and was on hemodialysis for several years. Recently underwent renal transplantation. Both the girl's father and the mother are otherwise healthy and have had chickenpox in their childhood. Which of the following should now be recommended? Okay, so what are they telling us here? He's old, fine, yeah, but the main thing is here, he's on hemodialysis and he just went under renal transplantation, which means he is taking now treatment to decrease his immunity in order for it not to go against, so he's immunocompromised, immunodepressed because of the transplantation. And now the question is, what should we do in this case? Because we treat him as a non-immunized patient or immunocompromised patient. In this case, we will give an IV acyclovir and a versus zoster immunoglobulin to the grandfather, and C would be the right answer. Okay, just again going over this. This is what we give to immunocompromised to prevent an infection. Is both the IV acyclovir and the zoster immunoglobulin. Now, giving pyrocyclovir is just primarily to an infection of a healthy adult. That's when we give a pyrocyclovir. A vaccine of ZV vaccine should be non-immunized healthy adults. Isolation to go to prevent, no. Chickenpox is continues 24 hours before the rash starts and until lesion begins. So there's no reason for isolation. And then it says zoster immunoglobulin to the grandfather for non-immunized pregnant women. We give VZ, zoster immunoglobulin, not to this adult, not to this elderly who's immunocompromised. Question number 3. A 7-year-old boy is brought to the pediatrician with fever and rash. The mother reports noticing fever and lack of appetite for 4 days. He just won't eat. As the child complains, painful swallowing. According to the mother, the rash is non-painful and non-pruritic and appeared about a day before the initial symptoms. Today, the diffuse rash has started to peel off. His vaccination status is completed. Last year, he suffered from chickenpox, which self-resolved within a week. On exam of the oropharynx, the tongue is swollen and bumpy, and tonsils are erythematosed with white patches. Skin exam reveals small, red, bumpy, sandpaper rash on his trunk and extremities, which the following is the most likely diagnosis. Now, if we're saying that the child is completely immunized, we're saying, okay, the patient has already received his MMR, okay, at least once here, 4 to 6, so we can exclude the measles and mumps. He's also got chickenpox already, so he's also immune. So what's left? Well, even if we didn't do the elimination, let's go for what we know. Patient is described with a strawberry tongue. He's described with tonsils, the white patches. He has sandpaper. All this indicates a scarlet fever. And that's why C is the correct answer. Question number 4. A 6-year-old boy is brought with convulsions to the emergency department, to the ER. He is agitated and not cooperative. The mother reports 4 days ago he developed mild flu-like symptoms. Today he was irritated and confused, then developed vomiting, fast breathing, and became difficult to arouse. On the way to hospital, she noticed a seizure. When asked about possible medications used, the mother replies, "I am not sure. I was at work and his grandmother watched him." No past history of seizures, a vital temperature 37.9, heart rate 104, respiratory rate 33, blood pressure 110/75, and 99% oxygen room temperature. Labs, serum ALT and SD are increased. Prothrombin timer prolonged. Total serum bilirubin is normal. Serum ammonia is increased, which will explain also the convolutions. He was given anticonvulsants and admitted to an ICU, and CT scan of the brain was done. Which the following is most likely to be taken by this child? Obviously, this child has a hepatoencephalitis occurring here. And if we're noticing there are stages, so he had non-specific symptoms, and then it became difficult to arouse, and so forth and so on, and then he had seizures. These are certain stages which are very similar to Reye's phenomenon. So in this case, what has the child been taking? What should not be given to a child would be aspirin, and that would be the salicylate. Acetaminophen actually should be given in these patients, unless of course they have a Kawasaki disease. So the answer is what the child has been taking is salicylate, and this is Reye's syndrome. Again, difficult to arouse, fast breathing, vomiting, so it's been building up. Question number 5. 5-year-old boy with a rash is seen by the pediatrician. Yesterday he had a headache and fever, 38.8. And this morning a rash appeared all over his body. He complains of severe itchiness. The rash started with small groups of tiny red papules on his chest and spread to the arms, legs, and face. The boy visits kindergarten, has no sick contacts at home. His vaccination status is partially completed. When he was younger, he was very sick after some vaccines, so I prefer to avoid further vaccines. Which of the following is a possible sequela of recurrent infections during adulthood? And in this case, although it hasn't described in the mere sense a proper with the vesicles and stuff of a chickenpox, and one would attempt to go to a different answer here, what would definitely be a recurrent only in adulthood would be shingles, usually after the age of 50, and that's why we many times recommend taking a vaccination at the age of 60. So this is shingles because of the dormant infection. Question number 6. A 6-year-old boy is brought to the pediatrician for the evaluation of a rash. According to the mother, it all started 4 days ago when her son complained of feeling weak. She noticed redness in her eyes and measured a temperature of 38.1. 2 days ago, a pinkish pinpoint rash appeared behind his ears and on his face, and subsequently spread to the rest of his body. The family immigrated from Serbia last year and has no complete documentation of the past medical history nor vaccination record. The mother was diagnosed with celiac disease when she was a child. On exam, the patient has numerous pink maculopapular coalescence over his face and trunk. Petachia is seen on the soft palate and uvula. What is the most likely diagnosis? So even when going, obviously he's feeling ill, but when we're talking about we don't have any documentation of the vaccinations, we're already thinking about, okay, most probably in this case, we're going through the MMR. So we can exclude C, D, and E straight off the bat, and we'll leave with the measles and rubella. What is distinctive with the rubella is that it starts usually from behind the ears and then continues down. So it's the behind the ears point, but not only that, it's also specifically the patches on the patella, which is also distinctive for rubella, and that is what the patient has. So it is rubella. Now, question number 7. An 18-month-old girl is brought to the pediatrician by her concerned mother. After she developed a high fever and a rash, the mother reports persistent fevers of 40. It's a very high fever for the past 3 days, so 40 Celsius, with minimum response to paracetamol. Yesterday, on the 3rd day of illness, when the child's fever finally started to decline, the child appeared to be recovering and noticed a spotty rash over her chest, which rapidly spread to the arms, legs, and neck. She has an up-to-date vaccination record and attends a daycare. On exam, a maculopapular rash is seen on the trunk and extremities. No oropharyngeal lesions are noted, and which the found is the most likely responsible for this presentation? So again, she is 80 months old. She has, she's still young, high fever, paracetamol is not working. Further illness, child has a spotty rash over her chest. A molecular papular rash is seen on the trunk and the extremities. So this is not a description as chickenpox. We can exclude the chickenpox. Even though the fact that it is saying she has an up-to-date vaccination record, we can't really exclude that much the MMR because this is an 18 months old girl, although we usually give it a much, we give it a little bit later. So the rash itself, it resembles much more of a rosy like rash, and therefore it would, in this case, be much more a Roseola Infantum. It's a high, very high fever, starts on the trunk, and then slowly spreads after a number of days. Without oropharyngeal lesions, I would usually there's a cervical lymphadenopathy in measles and in rubella. It's not chickenpox. I would say it's a Roseola Infantum, and this is the sixth disease. So that is the answer. Question number 8. A 4-year-old girl is brought to the pediatrician by her mother, who complains of a sudden appearance of red rash on her daughter's cheeks 2 days ago. According to the mother, throughout the past week, the girl was feeling sick and had a low-grade fever, headache, and running nose. The rash is worsened by hot showers and sun exposure. Her vaccination status is up to date, and there is no recent sick contact. On exam marked erythema of the cheeks with perola pallor is noticed. Which of the following is the most likely to be responsible for this presentation? So again, this is an easy one. This is a slapped cheek. This is the 5th so-called disease, and this is a B19. This is a paravirus, Erythema Infectiosum, slap cheek disease. Remember that the human herpes virus is a Roseola Infantum. The hepatitis E virus and acute hepatitis, especially affecting pregnant women, we wouldn't see that kind of redness on the cheeks. And Coxsackie eye virus is a foot-to-mouth disease causing hyperangina. Again, the cheeks wouldn't be red. Question number 9. 29-year-old woman with hereditary spherocytosis and a history of pigment gallstones is evaluated in the wards for marked anemia and fever. Earlier this week, she visited her primary care physician after she experienced flu-like symptoms such as fever, general fatigue, and abdominal discomfort. Empiric antibiotics was prescribed, but her symptoms was worsened. On exam, no skin rash or lymphadenopathy is observed. CBC, red blood cell count of 1.9, hemoglobin 5.9, hematocrit is 21%, MCV is 84, and the reticular count is about 0.1%. Serology and polymerase chain reaction identified the causative pathogen. She required several blood transfusions following 2 weeks. Full recovery was recovered. Which of the following is the most likely responsible for this patient's presentation? Now, what it seems is she's, especially with a reticular site of 0.1%, we're talking about most probably she had undergone a aplastic crisis, and therefore she needed to have this huge amount of blood transfusions. Now, aplastic crisis would not happen in the Coxsackie virus, so we can exclude that. We can also exclude the Coxsackie virus. We can also exclude rubella. So we can exclude A, B, and C. We're left with D and E. Now, the human herpesvirus 6 does not cause a plastic crisis. I believe that the answer is E. So E is the parvovirus B19. Yes, it's a plastic crisis, especially in patients with sickle cell disease. Okay? Right, guys, that's all for today. I hope you enjoyed this video. Check out our other videos. I'm Dr. Adam. Have a great day. Goodbye.